Hi friends, we are going to discuss Tit-bits in neonatology clinical practice part 2, in which we will discuss NICU related procedures. We will mainly focus on surfactant administration and UAC and UVC line placement, PICC line placement, and regarding chest X-ray. So first we'll start with some definition. If birth weight is less than 750 gram, then incredible low birth weight baby, and extreme low birth weight baby if is less than 1000 gram, very low birth weight if less than 1500 gram, and less than 28 week, then extreme preterm, 28 to 31 very preterm, 32 to 33 moderate preterm, and 34 to 36 late preterm. And IUGR baby, it is deviation from an expected fetal growth pattern, intrauterine growth restriction. It results from any adverse factor that affect the normal growth potential of the fetus. So in surfactant administration, prophylactic surfactant is given in less than 28-week period of gestation if one or more of the following criteria is present. If gestation week is 25 or less, no or incomplete antenatal steroid coverage, or PPV is given more than 1 minute. If any one of the criteria is present, then in less than 28-week baby, we will give prophylactic surfactant. And in early rescue surfactant is given in HMD babies on CPAP, and FiO2 is required more than 40%, and baby is on mechanically ventilated, and FiO2 is more than 35% is required. And give ensure if there is no asphyxia, good respiratory effort, and baby is stable hemodynamically. And umbilical artery catheter and umbilical venous catheter. So normal position should be in umbilical artery catheter, high position should be at the level of the T6 to T9, and length of the UAC should be 9.7 plus 2.5 times of birth weight. And in UAC insertion, resistance at the level of the anterior abdomen wall, and the second one is at the junction of the internal and common iliac artery. And in UVC umbilical venous catheter, the position of the tip should be in the inferior vena cava at or just above the level of the diaphragm. It could be 0.5 to 1 centimeter above the level of the diaphragm. And length of the UVC should be 5.6 into 1.5 times of the birth weight. And resistance at the level of the anterior abdomen wall, and when UVC enter one of the hepatic vein. And infusion fluid should be heparin 0.5 ml per hour, concentration of 1 unit per ml. In lateral X-ray, UAC and UVC pathway, UVC follow the trajectory of the umbilical vein into the liver. In APV, it is straight course, and lateral view it is more superficial. And UAC first passes caudally and then enter in the iliac artery. In APV, it is coiled pathway. In lateral view, it is closer to the vertebrae. So let us first discuss the UVC pathway. First catheter goes in umbilical vein, then left portal vein, then ductus venosus, then middle or left hepatic vein, and then inferior vena cava. So in this figure, the UVC correct position tip in the inferior vena cava at the level of the diaphragm. In this figure, the UVC has a wrong position. UVC has incorrectly placed in the right atrium, and it need to be reseated. And now let us discuss UAC pathway. Umbilical, first of all, catheter goes in umbilical artery, then anterior division of the internal iliac artery, then common iliac artery, and then goes in aorta. In this figure, the normal high UAC position at the level of the T6 vertebrae level. In this figure, the umbilical artery catheter is too high, just below the subclavian artery, and it need to pull back. So in this figure, in green, the umbilical artery catheter is normal high position, and in red, umbilical venous catheter is abnormal high position in either in right atrium or distal superior vena cava. And in this figure, the UVC is abnormal position in liver in red, and in green, abnormal high umbilical artery catheter position. So let us discuss the PICC line. In upper limb, PICC line length should be from the point of insertion along the venous pathway to suprasternal notch, and then to the right third intercostal space. And tip insertion should be in the superior vena cava, just proximal to caval atrial junction, and the tip should be well outside of the cardiac chamber. In preterm, it should be 1 centimeter outside, and in term baby, it should be 2 centimeter outside of the chamber. In lower limb, PICC line length should be from the point of insertion to umbilicus, and then the G-fisternum. And tip position should be in the inferior vena cava, just below the diaphragm. and confirmation of PICC line should be done, and always confirm the position of the catheter by performing X-ray. In during taking X-ray, use of radio opaque contrast 0.3 to 0.5 ml help in the assessing location of the catheter tip in the case of the small size catheter. And if catheter tip is away from the target, then it should be removed, and if it is proximal to target, then it should be pulled out back. Let us discuss the IV fluid or expressed breast milk by OG feed according to weight. In term baby, it should be on day 160 ml per kg, on day 280, on day 300, on day 4 120 ml per kg, on day 5 140, and on day 6 150 ml per kg onwards. And in preterm baby, on day 1 it should be 80 ml per kg, on day 2 95 ml per kg, on day 310, on day 425, on day 5 140, and on day 6 onward it should be 150 ml per kg per day. Let us discuss the calories and protein in 100 ml of. In human milk, in 100 ml calories are 67 kilocalorie and protein 1.1 gram in 100 ml, and in formula milk of 100 ml it calories are 78, protein is 2. In human milk fortification with prenaine, calories are 82 and protein are 2 gram per 100 ml. In human milk with high germ fortification in 100 ml, calories are 81, protein is 2.1. Similarly, human milk with lactose HMF, and in cow milk 100 ml, calories are 62 and protein is 3.3 gram in 100 ml. Let us discuss neonatal hyperbilirubinemia for neonatal jaundice. Kramer's rule. On face, if it is face icterus is present, then level is approximately 5 plus minus 1, and if it is on chest up to umbilicus, then it is around 7 plus minus 1, and if icterus is up to lower abdomen or thigh up to the knee, then level of bilirubin should be 10 plus minus 2, and if jaundice is up to the leg and whole upper limb, then level should be 13 plus minus 1, and on sole and palm it should be more than 15. Let us discuss appropriate compensation. In metabolic acidosis, CO2 should be washed out, so expected CO2 should be 1.5 times of bicarbonate plus 8 plus minus 2, Winter's rule. In metabolic alkalosis, for 10 milliequivalent per liter increase in bicarbonate, expected PCO2 increase should be 7 mm of mercury. And in appropriate compensation in respiratory acidosis, for 10 mm PCO2 increase, in acute respiratory acidosis bicarbs should increase 1, and in chronic respiratory acidosis bicarbs should increase 3.5 milliequivalent per liter. For respiratory alkalosis, for each 10 mm PCO2 was out, acute bicarb should decrease 2, and in chronic should decrease 4. Let us discuss how to read X-ray chest. First of all, we should maintain the asepsis when the radiographer enter in the NICU, and we should advise him regarding asepsis precaution. For appropriate diagnosis through chest radiograph, it must be analyzed in a systemic manner, in mnemonic ABCD FGHI you can remember. Assessment of quality should be in position, inspiration, exposure, and rotation, and bone and soft tissue, cardiac shadow, and then diaphragm and effusion, fields and fissure, great vessels, and mediastinum and median area, and then finally we should make an impression. Let us discuss position of chest X-ray. In AP view, apparent cardiomegaly is there because the heart is distant from X-ray film. As you can see in this figure, then in AP view, plate is placed posteriorly and X-ray beam come from anterior side. So comparatively large size of heart in AP view. And other difference in PA and AP view, scapula in AP view is superimposed on lung field, and clavicle is above the apex of the lung, and vertebra end plate are more prominent of vertebra in AP view. And exposure of chest X-ray, in underexposed film, white soft tissue, no vertebra usually seen, and more false diagnosis of infection is made. Compared to our exposed film, darker soft tissue and retrocardiac vertebra are easily seen and may misinfiltrate. For seeing bone and airway, usually our exposed film is preferred. And X-ray chest rotation. A well-centered X-ray medial end of clavicle are equidistant from the spinous process of the vertebral body projected between the clavicle. And if a rotated film, then the film is rotated on the side on which the distance appear greater. And the increased blackness of the one hemithorax always on the side of which the patient is rotated. Thank you.